Welcome to your deep dive. Today we are plunging into, well, the really powerful and sometimes complex world of central nervous system stimulants and related drugs.
Absolutely. This is such a critical area in pharmacology. Our mission today is to give you a clear, student-friendly breakdown of these key drug classes, for things like ADHD, narcolepsy, obesity, even migraines. We'll cover how they work, what the body does with them, and crucially, the nursing points you absolutely need to nail down.
And that system, the CNS, is all about balance, right? This constant push and pull between things that excite the system, like dopamine and norepinephrine, and things that inhibit it.
Exactly right. And CNS stimulants, fundamentally, they just throw that balance off. They crank up the excitation or they block the inhibition. Many of them act a lot like the body's own fight or flight system, the sympathetic nervous system. That's why we call them sympathomimetics.
Okay.
We're going to look at four main groups today: drugs for ADHD and narcolepsy, the anorexiants for weight loss, anti-migraine drugs, and finally, the analeptics.
Got it. So let's start with maybe the most common group people encounter. Treatments for ADHD and narcolepsy. ADHD is, well, it's everywhere, affects over 10% of kids, usually diagnosed around age 7.
Yeah, it's the most common psychiatric disorder in children. And then you have narcolepsy, those sudden, irresistible sleep attacks. And often, really frighteningly, cataplexy comes with it, that sudden muscle weakness triggered by strong emotions.
So what are the go-to treatments here?
Well, the first line options are usually the Schedule II drugs. These are the amphetamines like Adderall and the phenidates like methylphenidate, Ritalin.
Schedule 2, so high
Mhm.
potential for abuse.
Exactly. And their mechanism is pretty powerful. They stimulate key brain areas, the cerebral cortex and thalamus.
Yeah.
Well, they don't just block the reuptake of norepinephrine and dopamine, stopping them from being cleared away. They
Mhm.
actually force more of these neurotransmitters to be released into the synapse. It's this double whammy that really boosts alertness, elevates mood, and helps with focus on tasks.
That dual action explains the effectiveness, but also, like you said, the high abuse potential and the strict controls. But there must be alternatives, right, for people who maybe can't take these or want to avoid the risks.
There are, and this is important. Look at atomoxetine. It's technically not a stimulant. It works differently. It's a selective norepinephrine reuptake inhibitor, or NRI.
Okay, so it just blocks the reuptake, doesn't force release.
Correct. And a huge practical difference is that it is not a controlled substance.
Ah, so that changes things for prescribing and refills.
Right.
What does that mean for you, the listener, if you're managing these prescriptions?
Well, clinically, the abuse potential is significantly lower, which is a big plus for patient safety. And from an administrative standpoint, it's easier. Prescriptions can often be refilled with just a phone call, unlike the strict rules for Schedule II drugs.
That's a major convenience factor.
Definitely. And then we also have some newer agents, mainly for narcolepsy, like modafinil and armodafinil. These are Schedule 4.
Schedule 4. So lower abuse potential than the amphetamines, but still controlled. They promote wakefulness too, so how do they differ? Do they have fewer of those speedy side effects?
They generally do. They seem to work differently. Instead of hitting the excitatory side as hard, they seem to reduce the effects of GABA.
GABA. That's the main inhibitory neurotransmitter, right? The brain's main brake.
Exactly. So by reducing the effect of the brake, you essentially promote wakefulness. It tends to feel cleaner for many patients, fewer jitters, which explains why they land in Schedule 4, not 2.
Okay, but even with these newer agents or non-stimulants, there's still a risk of side effects, that sort of speeding up effect.
Oh, absolutely. You can still see increased heart rate, higher blood pressure, anxiety, trouble sleeping, GI upset. It's almost unavoidable when you're manipulating these core systems.
And one big concern, especially with kids on long-term ADHD meds, is physical growth suppression. How do clinicians handle that?
This is where nursing is absolutely vital. Consistent monitoring is key, tracking height and weight at every visit. To mitigate the growth risk, specialists often recommend drug holidays.
Taking weekends off or summer breaks?
Precisely. It gives the body a chance to sort of catch up, but monitoring is constant. And we have to remember some critical safety alerts. Atomoxetine has that black box warning about increased suicidal thinking in adolescents.
That's serious.
Very. And no stimulant, or atomoxetine for that matter, should be given if the patient has known structural heart problems. And definitely not if they've taken an MAOI, a monoamine oxidase inhibitor, within the last 14 days. That interaction is dangerous.
Okay, good flags to remember. That focus on norepinephrine actually leads us pretty neatly into our next category,
Mm.
anorexiants, the drugs for obesity, because some of them use similar pathways, don't they?
They do. We're usually talking about using these drugs for patients with significant obesity, a BMI over 30, or maybe over 27 if they also have issues like high blood pressure or diabetes.
And what are the options here?
Well, you have the sympathomimetic stimulants, like phentermine. It's chemically related to amphetamines, yes, but it's Schedule 4, indicating lower abuse potential. It works mainly by suppressing appetite centers in the brain, using those dopamine and norepinephrine pathways we talked about.
Right, so because it's still a stimulant, that timing issue is key for nursing instruction. Take it early in the day.
Yes, absolutely. Typically in the morning, or at least 4 to 6 hours before bedtime, otherwise it can really interfere with sleep. And it's crucial to emphasize these are short-term tools. They must be combined with diet, exercise, and behavioral changes.
Okay, but isn't there another major player in the weight loss drug world that works completely differently? Something that avoids the CNS stimulation altogether?
Ah, yes, orlistat. You might know it as Xenical, or the lower dose over-the-counter version, Ali. This one is fascinating because it completely sidesteps the brain.
Right, it works locally in the gut. It's a lipase inhibitor.
Exactly. Lipase is the enzyme your body uses to break down dietary fat so it can be absorbed. Orlistat blocks this enzyme right there in the GI tract. The result: about 30% of the fat you eat just passes right through, unabsorbed.
So no CNS stimulant side effects like anxiety or palpitations. But it creates its own set of issues, right?
Mm.
Particularly around side effects and patient teaching.
Oh, definitely. This is where patient education is paramount. If a patient on orlistat doesn't stick to a low-fat diet, and we generally mean keeping dietary fat under 30% of total daily calories, they're in for a rough time.
What happens?
Well, all that unabsorbed fat moving through the intestines can cause some really unpleasant GI effects. We're talking oily spotting or leakage, increased flatulence, sometimes even fecal urgency or incontinence. It can be quite distressing.
So adherence to the low-fat diet isn't just for weight loss. It's to manage the side effects of the drug itself.
Precisely. It makes the therapy tolerable. And another key point, because you're blocking fat absorption, you're also potentially blocking the absorption of fat-soluble vitamins.
Vitamins A, D, E, and K.
Correct. So patients taking orlistat usually need to take a multivitamin supplement containing these, typically spaced a couple of hours away from the orlistat dose to prevent deficiencies.
Okay, that's a really different mechanism and set of considerations.
Hmm.
Let's shift gears now from managing chronic conditions like obesity to tackling acute problems, specifically migraines.
Right, migraines. More than just a bad headache. They're typically recurring, have that throbbing or pulsatile quality, often just on one side, and can last anywhere from 4 hours to 72 hours.
And often come with nausea, vomiting, sensitivity to light and sound.
Hmm.
It can be debilitating.
Totally debilitating. And the current thinking often links them to changes in serotonin levels in the brain, maybe a temporary decrease. So
Yeah.
our main abortive therapies, meaning drugs you take to stop a migraine once it's started, target serotonin.
And that brings us to the triptans, right? Like sumatriptan.
Exactly. The triptans are serotonin receptor agonists. They specifically stimulate certain serotonin receptors, the 5-HT1B and 1D types, which are found on blood vessels in the brain.
And stimulating those receptors causes vasoconstriction.
Yes, potent vasoconstriction. The idea is that during a migraine, these cranial blood vessels dilate too much, contributing to the pain. Triptans constrict them back towards normal. They also seem to reduce the release of inflammatory substances, these neuropeptides, that add to the pain and inflammation.
Okay, so targeted vasoconstriction. That sounds effective, but also like it carries some risks.
It absolutely does. This vasoconstriction is the main reason for the big safety alert with triptans. They are generally contraindicated, meaning you should not use them in patients who have serious cardiovascular disease.
Like coronary artery disease, angina, uncontrolled hypertension, history of heart attack or stroke.
Precisely. Because the drug deliberately constricts blood vessels, you wouldn't want to give it to someone whose cardiovascular system is already compromised. It could potentially trigger angina or worse.
And what about interactions? We mentioned serotonin. Are there issues if someone is already on, say, an antidepressant?
Yes, a major one: serotonin syndrome. If a patient is taking an SSRI, a selective serotonin reuptake inhibitor, or especially an MAOI, adding a triptan can overload the serotonin system.
And that causes what?
It can cause a range of symptoms, from mild things like nervousness and tremors to severe issues like really high blood pressure, high fever, muscle rigidity, even seizures. It can be life-threatening. So triptans should not be taken within 2 weeks of using an MAOI. Caution is also needed with SSRIs.
Good to know. And for using triptans effectively, what's the advice?
Take it early. At the very first sign that a migraine is coming on, don't wait until the pain is severe. That gives the medication the best chance to work.
And they come in different forms, right? Not just pills.
Correct. You can get oral tablets, but also nasal sprays and subcutaneous injections the patient can give themselves. These non-oral forms are a huge advantage if the migraine causes significant nausea or vomiting, making it hard to keep a pill down.
And they work faster.
Much faster. Nasal sprays and injections can start providing relief within maybe 10 to 15 minutes, whereas a pill might take an hour or two to really kick in.
Okay. That covers migraines. Our final category then is analeptics. These are respiratory stimulants. Sounds like something for more acute situations.
Generally, yes. You'll see these used more in hospital settings, like the ICU, the PACU, or the NICU. Their main job is to stimulate breathing.
In what kinds of situations?
Several key ones. Neonatal apnea, where premature infants have pauses in their breathing. Also, for respiratory depression that can happen after anesthesia. And sometimes to help manage hypercapnia, that's high carbon dioxide levels in patients with severe COPD.
What drugs are we talking about here?
The main class is the methylxanthines. This includes drugs like caffeine, theophylline, and aminophylline.
Caffeine, like in coffee.
Chemically related, yes. Caffeine itself is used, often as caffeine citrate, especially for neonatal apnea. The methylxanthines generally work by inhibiting an enzyme called phosphodiesterase. Blocking this enzyme leads to an increase of a substance called cyclic AMP, or CAN-MMP.
And more CAMP leads to?
It leads to relaxation of the smooth muscles in the airways, which helps breathing, and it also stimulates the CNS. Caffeine has an additional mechanism, too. It blocks adenosine receptors in the brain. Adenosine promotes sleep, so blocking it promotes wakefulness and respiratory drive.
Is there anything else besides methylxanthines?
There's also doxapram. It works a bit differently, primarily stimulating the part of the brainstem, the medulla, that senses carbon dioxide levels in the blood.
Okay. Are there major safety concerns with these?
There's a really important one, especially regarding newborns. Doxapram is generally contraindicated in neonates.
Why is that?
The injectable form contains benzyl alcohol as a preservative. In infants, especially premature ones, benzyl alcohol can be toxic. It can displace bilirubin from its binding sites, potentially worsening jaundice or causing a dangerous condition called kernicterus.
Okay. So caffeine citrate is the preferred option for neonatal apnea.
Yes, much safer profile for that specific use. For all analeptics used in acute care, the nursing focus has to be on intense monitoring. We're talking constant vigilance over vital signs, especially heart rate and blood pressure, which can increase, and also checking deep tendon reflexes. Hyperactive reflexes can be an early sign of overdose.
Makes sense for drugs stimulating the core respiratory drive. Okay, let's try to pull all of this together. Looking across all these different CNS stimulants and related drugs, what are the overarching themes for nursing practice?
You know, two things really stand out from this deep dive. First, the absolute necessity of a thorough cardiovascular assessment. And second, the critical importance of careful administration and patient teaching.
Let's unpack the cardiovascular part first. Why is that number one?
Well, think about it. Whether it's ADHD drugs, stimulant anorexiants, triptans causing vasoconstriction, or even analeptics ramping things up, almost all these drugs put some degree of stress on the heart and circulatory system.
So before starting any of these,
you absolutely must assess for any pre-existing heart conditions, structural abnormalities, uncontrolled hypertension, or cerebrovascular disease. These are often contraindications, as we've discussed. You need to know the patient's baseline cardiovascular status before you potentially challenge it with one of these medications.
Okay, assessment priority number one, cardiac status. What else is crucial in that initial assessment?
History of substance abuse is huge, especially when considering those Schedule II stimulants like amphetamines. You need that baseline height and weight, particularly for kids on ADHD meds or anyone starting an anorexiant for ongoing monitoring. And always check for recent MAOI use. That 14-day window is critical across several of these drug classes due to interaction risks.
Got it. Now, moving to implementation, you mentioned careful administration and teaching. What are the key finesse points here?
It really comes down to helping the patient use the drug correctly and safely, and monitoring the effects. For many of these conditions, ADHD, obesity, migraines, encouraging the patient to keep a journal can be incredibly helpful.
A journal tracking what?
Daily activities, what they ate, when they took their medication, and how they felt, any symptoms, any side effects, any migraine triggers they noticed. It helps both the patient and the prescriber see patterns and track how well the therapy is actually working.
Practical advice. What about specific dosing instructions?
Timing is key for stimulants. That last dose for ADHD really needs to be 4 to 6 hours before bedtime to minimize insomnia. And reminding patients never to crush or chew extended release formulations that could cause a dangerous dose dump.
Right. And for something like the migraine nasal spray.
Technique matters. You'd teach the patient to gently blow their nose first to clear the passage, close off one nostril, then spray into the open nostril while breathing in gently through the nose, then hold their breath or breathe gently for maybe 10-20 seconds. Doing it right maximizes absorption.
Okay. And finally, the safety net. What are the absolute must-report immediately symptoms we need to empower patients to recognize?
Any chest pain or palpitations could signal cardiac distress. For triptans or older ergot alkaloids, sometimes used for migraines, any tingling, numbness, or pain in the fingers or toes needs immediate reporting, as it might indicate excessive vasoconstriction cutting off circulation.
And for atomoxetine.
Critically, any emergence of suicidal thoughts or worsening mood or significant changes in behavior needs to be reported to the prescriber right away.
So, wrapping this all up, what's the big picture for you, our listener? This deep dive really underscores a kind of pharmacological balancing act. Whether we're pushing the CNS with stimulants, clamping down blood vessels with triptans, or even bypassing the brain entirely like orlistat does.
The common threads are the need for rigorous nursing assessment, always starting with that cardiovascular check and really precise patient teaching about how and when to take the medication and what to watch out for.
It connects back to that core idea of manipulating the body's systems carefully.
It does. And, looking at the bigger picture, especially for chronic conditions like migraines, the landscape is shifting. We focused a lot on the drugs, the pharmacology, but our sources also mentioned the rise of non-pharmacological approaches. For instance, the FDA has actually approved a device called the Cephaly unit. It's a 10NS device transcutaneous electrical nerve stimulation worn on the forehead for migraine prevention. It stimulates the trigeminal nerve.
That's fascinating. A completely different way to tackle the problem without systemic drugs.
Exactly. And it leads to a really interesting question for the future, doesn't it? As technology gives us more tools like this that don't rely on traditional drug pathways with all their potential systemic risks and side effects,
Yeah.
how quickly might clinical practice start shifting? Will we see a faster move away from relying solely on drugs for managing chronic, debilitating conditions like migraine or even chronic pain towards integrating these newer, non-pharmacological technologies? Something for you to think about as you continue your learning journey.